Okay, welcome back to part 5. This is part 5 of 5. So we're going to pick up where we left off last time. I showed you this case of splenic infiltration, and I asked you what else could this be? Lymphoma, leukemia, myeloproliferative disease are all good. Things like mononucleosis are possibilities. Things like thalassemia are possibilities. Things with very large spleens could be malignant or can be benign. One of the challenges, of course, when you have very large spleens like this is spontaneous bleeding. Here's that same patient. You can see how large the spleen is in volume, and the spleen extends down way into the pelvis. In this example, patient had CLL with flank pain, and you can see spontaneous intrasplenic and perisplenic bleeding. So one of the things we always worry about of infiltration in the spleen, most commonly infiltration by malignancy, but also it can be infiltration by non-malignant things. Again, mononucleosis would be a really good example. And here you can see the act of bleeding. We wrote an article, Yasrub and myself, a few months ago. It's an emergency radiology of a bunch of interesting cases of spontaneous splenic bleeding without trauma. And it's worthwhile looking at that article. We'll give you some other good examples and some things to think about. But again, you may not see active bleeding like we do in this case. That's pretty infrequent. But it's obvious the spleen has ruptured, and this perisplenic and intrasplenic blood, also nicely shown here on the cinematic rendering. Now, again, we speak about splenic involvement is seen at presentation in about 1/3 of all Hodgkin's lymphoma and up to 40% of patients with non-Hodgkin's lymphoma. One of the things to remember, and this is a bit of an older article, is that just because there's splenic involvement, you may not see a focal lesion on CT or MR. It may be more infiltrating. PET can be very helpful in these cases. Again, the infiltration of the spleen can be diffuse, like the cases I showed you a few moments ago, or it can be discrete nodules, single or multiple nodules. You can see infarction of the spleen. And again, these lesions do have a range of appearances on CT, MR, and ultrasound. Most of the time, portal venous phase imaging is ideal for seeing the lesions and looking for complications. Now, when you have lesions in the spleen, we said look around. Well, now I see multiple splenic lesions, but I see multiple hepatic lesions. What am I thinking about? First thing I think about is lymphoma, and then quickly I add metastatic melanoma. If the patient is febrile, particularly if it's an immunosuppressed patient, and the lesions are small, I gotta say it's infection. Candidiasis would be a very good thing to think about. But one of the things that we see often at presentation, particularly younger females, multiple splenic lesions and hepatic lesions, and it ends up being sarcoidosis. Often the case is the patient doesn't even know they have sarcoid, and the scan is done for trauma, let's say mild trauma, and then everybody is saying, oh my goodness, the patient has lymphoma. So again, you want to think about sarcoid. Sarcoid is a systemic inflammatory condition characterized by non-caseating granulomas. Splenic sarcoid at CT varies from multiple solid hypodense lesions of varying sizes. It's typically not going to be hypervascular. And again, you can see adenopathy because sarcoid can have adenopathy. You can see disease in the chest, right? Hilar adenopathy, mediastinal adenopathy, and of course, liver involvement. Sarcoid can affect all organs of the body. And again, sarcoid is a great mimicker. So when we do conference and I show a case that's lymphoma, people will often say, well, lymphoma is the first thing I think about. But the second thing I think about, perhaps, sometimes they'll say melanoma, patient's a bit older, or sometimes they'll bring up sarcoid, because sarcoid is really a great mimicker. Splenic sarcoid is generally manifested by homogeneous splenomegaly that is present in approximately 40% of patients and much more rarely bifocal splenic lesions. We see lots of sarcoid, but not that many splenic lesions, and that's why people often don't think about it. But here's a wonderful example. Again, melanoma, lymphoma. This is sarcoidosis. Big spleen, multiple lesions in both the liver and spleen. Here's sarcoid with multiple splenic lesions, small nodes present by the peripancreatic region. Again, you can understand why you'd be thinking about lymphoma in this case. And here's another patient with multiple splenic lesions. They're smaller. Patient was febrile. You might think about an infectious etiology. Again, fungal infections like Candida would be possibilities. So again, remember some of the things we think about. Sarcoid are often younger age patients, 30 to 50. African Americans affected more commonly than whites. Pulmonary complications, not uncommon. Now you can obviously have extensive adenopathy from lymphoma in the mediastinum and hilar regions. But again, if you see some adenopathy, at least think about sarcoid. And symptoms, fatigue, fever, weight loss are good for sarcoid, but are good for many things, surely malignancies. And again, some comments. The appearance of sarcoid, as we mentioned, in the spleen, and this is also true in the liver, is focal nodules, single nodules, multiple nodules, or diffuse infiltration. Now, there are other things I should mention with big spleens. Beta thalassemia, large spleen could be lymphoma. Something looks like it's infiltrating. But the key thing is looking at the spine. In the presacral region, there's extramedullary hematopoiesis here, and there's bony changes in the spine. This was beta thalassemia, very nicely shown also on the 3D rendering. The most common sites of extramedullary hematopoiesis in the abdomen are liver, spleen, and lymph nodes. Signs and symptoms include hepatosplenomegaly, abdominal discomfort, and shortness of breath. So again, extramedullary hematopoiesis is something to think about with the big spleen, but especially when you have bony changes as well. Now, one thing I'll mention, moving away from tumors, you can see vascular pathology in the spleen, from aneurysms to pseudoaneurysms. Aneurysms are often small, but when they get over 2 centimeters, there's often embolization will be done. Pseudoaneurysms are more concerning because they present with more frequent complications, including spontaneous rupture. In general, splenic artery aneurysms are the third most common intra-abdominal aneurysm, more common in women, but more likely to rupture in men. And again, associations, atherosclerotic disease and hypertension. Then, of course, portal hypertension, cirrhosis, pregnancy, and liver transplantation. One of the concerns with splenic artery aneurysms is a patient with cirrhosis who they're considering doing a transplant. You would worry that that splenic artery aneurysm can rupture. Pseudoaneurysms are more common with other inflammatory things: trauma, post-op complications, peptic ulcer disease. But number one on the list to me is pancreatitis. Splenic artery pseudoaneurysms occur in pancreatitis, not the first episode, but in patients who have repeated episodes of pancreatitis, where the pancreatic fluid erodes the vessels and causes pseudoaneurysm. Presentations from abdominal pain to melena. Pseudoaneurysms rupture in up to 37% of cases, and when they rupture, the mortality approaches 90%. So when you start seeing what looks like a pseudoaneurysm because of stranding around the vessel outpouching, you need to be aggressive in those patients. In this article by Bird, splenic artery aneurysms over 2 centimeters or equal to 2 centimeters, or any aneurysm with features suspicious for a pseudoaneurysm, should be referred to interventional radiology for consideration of treatment. If an aneurysm is under 2 centimeters, it can be followed annually with CT or MR. So again, very good recommendations. Nice example, 1 centimeter splenic artery aneurysm, will be followed. Here's a patient with cirrhosis and portal hypertension and splenomegaly. You can see approximately a 2-centimeter aneurysm, and the most commonly near the hilum of the spleen. Here's a patient with splenic artery aneurysm with some faint calcification. The splenic artery in this patient is markedly tortuous. You can see patients with splenic artery aneurysms at times have multiple splenic artery aneurysms, but can have other aneurysms present, so you want to look carefully. Here's a patient with splenic artery aneurysm who also had a GDA aneurysm. Splenic artery aneurysms get large and over 2 centimeters that typically will be operated on. Here's a giant splenic artery aneurysm in the 5-centimeter range. And here are some 3D images nicely showing you that aneurysm. These are the ones with a high propensity to rupture. These are the ones that will be treated aggressively, and typically surgery with resection will be done. I mentioned pseudoaneurysms, the inflammation around the aneurysm. Again, this can easily rupture, most commonly due to pancreatitis. Again, repeated episodes of pancreatitis can be due to trauma or other GI infections at times. Here it is very nicely shown with MIP imaging. I think using 3D, particularly MIP, and some volume rendering or cinematic rendering can be very helpful in these patients. Here's another patient who passed out while lifting weights. This patient was very lucky. This was a splenic artery pseudoaneurysm that bled, and he eventually had it embolized and has done very well, but no longer lift weights. You can see the irregularity of the aneurysm or pseudoaneurysm and the soft tissue stranding around it, which in this case, in part, represents blood. Now, when we talk about the spleen, we also talk about what I would call benign lesions that are probably more common than malignancies. Splenic infarction, patients with IV drug abuse, patients with all sorts of infectious etiologies. We talk about segmental versus global infarction. Global infarction, where the entire spleen is involved, is less common. It can be due to trauma, but focal infarcts, single or multiple, are more common. Splenic infarcts, it's a gamut of things: endocarditis, atrial fib, sickle cell disease, lymphoma, splenomegaly. And again, with infarcts, they can resolve over time simply by shrinking and causing scarring in the spleen. Occasionally, you can have infarct and infection, and in those patients, the patient usually needs a splenectomy. Here's a global infarct of the spleen. The entire spleen is infarcted, and that's one of the things you get post-surgery. I mentioned trauma as a possibility. This patient's post-Whipple's. It's rare to get global infarction of the spleen post-Whipple's, but this is a good example, very nicely shown here in the coronal view as well. Here's a patient with adenocarcinoma of the pancreas with recurrence with a large splenic infarct, very nicely seen here. Subnormal enhancing spleen. There's the infarct. There's the ascites. And there it is very nicely on the coronal view as well. Now, sickle cell disease is something we see a lot of. In patients with SS disease, autoinfarction, small spleens densely calcified are very common. There's a range of things: SC disease, sickle thalassemia. Sometimes the spleen is normal in size, sometimes the spleen is enlarged. SS disease has the smallest spleens due to autoinfarction. And if you don't look carefully, sometimes you don't even see the spleen present. There's a nice example of autoinfarction. Here's another example, dense calcification. Here's another example, the spleen is a bit larger, but diffuse calcification, very nicely shown on the coronal views as well. Here's a patient with sickle cell disease with a normal to slightly enlarged spleen, but acute splenic infarction. One thing we also think about with sickle cell patients, but also patients with thalassemia, or SC disease, we talk about sequestration in the spleen, where the spleen enlarges and it looks like an infarct, but it's more mottled. And sequestration can lead to rupture or other complications, a very important diagnosis. And here's a few more looks at that patient's splenic infarcts. Really a nice example of what I would call global infarction. Now, splenic abscesses, I do want to mention, they're rare. Risk factors: diabetes, alcohol abuse, IV drug abuse. The challenge with splenic abscesses, they can look like tumor. They can overlap. I mentioned if you're immunosuppressed, you have unusual abscesses which are fungal and multiple small lesions present. But again, splenic abscess can be very, very challenging. Pyogenic splenic abscesses is most often due to hematogenous spread of infection, with the risk factors including diabetes, immunosuppression, steroid therapy, and sickle cell disease. Patients present with typically left upper quadrant pain. Abscesses can be single, multiple, or multiloculated. A thing to remember about splenic abscesses, they can be bacterial or mycobacterial or fungal. One of the things is they're great mimickers, right? Because a low-density lesion in a spleen in a patient who's febrile, well, that could be lymphoma. So lymphoma and splenic abscesses can present with similar history and similar presentations. And again, there is a lot of bacterial microbes, including E. coli, staph, and strep, and salmonella, that can cause abscesses in the spleen. Here's a nice example of a splenic abscess, low density, poorly defined. But if I told you this was lymphoma, you would not argue with me. Another example, here really is a markedly abnormal spleen in terms of enhancement, a combination of infarct and abscesses. This was a patient who worked at the Aberdeen Proving Grounds and had brucellosis. This was an immunosuppressed patient, multiple tiny lesions in the spleen. Again, the history gives it away. If this was a regular patient with multiple small lesions, you might say cysts, hemangiomas. But an immunosuppressed patient, you probably have another scan which showed the spleen looking normal. But even if I didn't have a prior scan, I still would have said infection, and I worry about fungus, and aspergillosis is always at the top of my list. Fungal microabscesses usually occur in patients with prolonged neutropenia. Predisposing factors include immunocompromise due to HIV, chemotherapy, immunosuppression, and immunodeficiency. Again, not just aspergillosis, candidiasis, and even crypto are things you need to think about. I do like candidiasis because that's the most common one. Someone was asking me about presentations. I remember way back when the first time I was visiting professor was University of Michigan, and the late, great Gary Glazer, who was a great friend, was quizzing me because they had, I was a speaker for grand rounds at the Detroit Radiologic Society the next day, and you went to University of Michigan the night before, and they quizzed you. Those were the old days. The first case he showed me was a case of splenic candidiasis, and I got it right. I wonder, and I got all the rest of them right. I think he gave me easy cases. I'm sure he did. But I always wonder what would have happened to my career if I got that first one wrong. Here's another example of candidiasis. Multiple small lesions, but nowhere as impressive as the prior case. That patient also has liver lesions. One of the things with fungal infection of the spleen, you got to look carefully at the liver and the kidneys. Both organs can be involved, and you can see some tiny lesions in the patient's left kidney as well. So we started 5 different lectures ago, talking about how do we work up the incidental splenic mass at CT. What do we ignore? What do we pursue? Again, we mentioned that incidental findings with no symptoms, no history, most of the time we can leave alone. When patients have fever or weight loss or other symptoms, You got to aggressively think about the possibilities. We've looked at many different cases, some challenging cases you'll rarely see. We talked about some of the difficult differential diagnoses. And again, I think if you work really hard, you'll be able to do really well. In patients with known malignancy or with constitutional symptoms or pain localized to the left upper quadrant or epigastrium, although most masses will be benign, such patients require further assessment. So again, asymptomatic patients, think of all the possibilities, look carefully at the images. Most of the time, it's going to be benign and you're not going to be pursuing it. But in the right group of patients, you are going to be pursuing the diagnosis. So with that, I thank you for your attention and hope this series of lectures was helpful to you. Thanks very much. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.